Today, we're going to learn a skill that doctors spend years mastering, how to actually see inside the human body by reading a chest CT scan. And we're going to do it by cracking open a legendary medical textbook that totally changed the game on how this stuff is taught. Let's jump in. So, it's a really fundamental question, right? How do you go from a drawing in a book to understanding a living, breathing person? For a long time, the answer was just plain old anatomy class, memorizing diagrams, looking at cadavers. But there's a massive leap between a flat, static drawing and the dynamic systems inside a real patient. The true challenge is making that textbook knowledge click into a 3D understanding you can actually use to help someone. To bridge that exact gap, a whole new way of thinking has come about, sometimes called living anatomy. Instead of just memorizing diagrams, this method weaves dynamic scans, like CTs, right into the learning process from day one. It flips the script from just, memorizing parts in 2D to truly understanding them in 3D and seeing how it all applies in the real world. You're learning anatomy as it actually appears inside a patient. So here's our game plan. First, we'll break down the problem with the old way of doing things. Then we'll look at the revolutionary solution. After that, we're going to get hands-on, decoding a real CT scan and mapping out the lungs ourselves. And finally, we'll see how all this helps doctors develop that clinical eye for making critical diagnoses. Okay, let's get into it. We're starting with the problem itself. Why did medical training even need to change? Well, it all comes down to the huge gap between learning something in a classroom and actually needing to use it. Yeah, research from medical schools has flagged this thing called a time lag. A student might spend their entire first year mastering anatomy, but then it could be 2, maybe 3 years before they're actually in a hospital trying to apply it. And in that time, a lot of that crucial knowledge just fades away. Even worse, students start to feel like, why am I learning this? Which, totally kills motivation. So what's the solution? It's simple, really. Don't wait. You integrate the two fields from the very beginning. By teaching basic anatomy right alongside clinical radiology, you connect the what is it with the how we see it. All of a sudden, students get it. They see why it matters, and that knowledge actually sticks. Anatomy stops being this abstract academic thing and becomes a powerful, practical tool for solving problems. And our guide for all this is an absolute legend in medical education, Felson's Principles of Chest Röntgenology. Seriously, this is not your typical heavy textbook. For decades, it's been famous for its one-of-a-kind learning style. It's written like a conversation, constantly asking you questions, quizzing you, making sure you're actively figuring things out, not just passively reading words on a page. And you know what? This approach works. It really works. Just look at the data from that study on the integrated course. A whopping 90% of students said it improved their understanding of anatomy. Another 90% said they saw how relevant it was for their future careers. And maybe the most important part, 88% said it made them more interested and motivated to learn. That's what happens when you make knowledge useful right away. Okay, enough with the theory. It's time to get practical. We are going to put Felson's method to work and learn the absolute basics of how to decode a CT scan. So what is a CT scan anyway? Well, think of a normal X-ray as just a shadow. It's flat, 2D, and everything is just piled on top of everything else. A CT scan is so much more sophisticated. It takes hundreds of X-ray slices from all these different angles and then uses a powerful computer to build them back into a detailed cross-sectional picture. It's almost exactly like looking at one perfect slice from a loaf of bread. Now, to navigate all this 3D data, doctors look at the body in 3 standard ways, or planes. The axial plane is the most common one. It's a top-down view like you're slicing the patient from head to feet. The coronal plane is a front-to-back view, slicing them from their face to the back of their head. And the sagittal plane is a side view, slicing from left to right. Getting these 3 planes down is the key to building that 3D model of the patient in your head. Okay, so why do some things look black and other things look white on a scan? It all comes down to density, and that's measured on something called the Hounsfield scale. Things with very low density, like air in your lungs, don't block the X-rays, so they show up as pure black. Water and soft tissues are kinda in the middle, so they look gray. And then you have really dense stuff like bone, which blocks almost all the X-rays and shows up as bright white. Now, this is where it gets really cool. What you're looking at here are 2 views of the exact same slice of the patient. On the left, we're using what's called a lung window. The settings are tweaked to show off all the delicate, air-filled parts of the lungs with amazing contrast. Then, on the right, we've switched to a mediastinal window. The lung detail is kind of gone, but now, bam, we can clearly see the heart, the big blood vessels, and all the other important stuff packed in between the lungs. All right, we've got the basics down. Now it's time to do what Felson's textbook does best: put our knowledge to the test. Let's see if we can actually spot some key structures on a real CT scan. Okay, here's our first test image. This is an axial slice, which means we're looking up from the patient's feet toward their head. And this specific slice is right at the level of the carina. That's the spot where the main windpipe, the trachea, splits into two branches, one for each lung. So take a good look at that structure labeled with a C. You see how it's a black tube with a thin white wall? Now, based on what we just talked about with density, what do you think that is? I'll give you a second. If you guessed the airways, you are absolutely right. That's the trachea at point C, splitting into the main bronchi. Since they're full of air, which has super low density, they look black. And the walls, made of denser cartilage and tissue, show up as that thin white border. See? It's all starting to make sense. Okay, next question. Check out those bright white branching lines all throughout the lungs, like at points A and B. What could those be? Think about it. What else is inside the lungs besides air? You got it. Those are the pulmonary arteries and veins. They're filled with blood, which is basically dense salt water, making it way denser than the air around it, and that's why they pop as bright white against the black background of the lungs. This is the basic map of the lung: airways and blood vessels running right next to each other. Fantastic. Now, let's switch things up. This is the exact same slice we were just looking at, but now we're in the bone window. The details inside the chest get washed out, but the skeleton holding it all together is now perfectly clear. All right, final pop quiz on this slice. Let's map out the skeleton. Can you find the sternum or the breastbone right up front? That's B. How about a rib wrapping around the side? Yep, that's A. Now in the back, can you spot the scapula, the shoulder blade? That's C. And finally, the big round vertebra of the spine right in the center? That's D. And just like that, you've successfully identified the major bones in a chest CT scan. So here's the real takeaway. Learning to read a scan isn't about memorizing a list of 1,000 diseases. The secret is learning what normal looks like so perfectly that the second something is wrong, it just jumps off the screen at you. Once you know what's normal, you can start to see what's not. And that brings us to what Felsen calls a clinical pearl. An image by itself is rarely the whole story. The exact same white spot on a scan could be a dozen different things. The image gives you a pattern, but it's the doctor's job to combine that pattern with the patient's story, their age, their symptoms, their history, to figure out the real diagnosis. And this illustrates that point perfectly. Let's say we see this weird spot, a dense white area in the top of the right lung. The pattern is called alveolar consolidation, but what is it? Well, if the patient is a 20-year-old with a fever and a cough, it's almost definitely pneumonia. But what if the patient is a 68-year-old smoker who's been losing weight? Now you have to worry about lung cancer. Or if they're a 30-year-old who just got out of prison and has night sweats, that could easily be tuberculosis. Same image, 3 totally different patients, 3 completely different diagnoses. That is clinical reasoning in a nutshell. Okay, it's time for our final challenge. I want you to take a really close look at this scan. Based on everything we've just learned about what a normal chest looks like, can you spot what's wrong here? Take a second. So, did you see them? First, look at the lungs themselves. They aren't clean and black. They're speckled with all these little white spots or nodules. That is definitely not normal. But don't stop there. Look closely at the ribs on the patient's right side. See how one of them looks like it's been eaten away? That's a rib metastasis, cancer that has spread to the bone and is destroying. So when the doctors put all of these clues together, they found the source. This patient had a kidney tumor. The cancer had spread from that kidney, sending little seeds into the lungs to form those nodules and into the skeleton to create that lesion in the rib. The CT scan revealed the entire story, connecting all the dots into one single diagnosis. So let's just recap. In just a few minutes, you've learned why mixing anatomy and radiology together is such a powerful way to learn. You now get the basics of a CT scan, the planes, the windows, the densities. You've actually practiced identifying the main structures in the chest. And most importantly, you've learned the secret to developing a clinical eye. Context is everything when you're turning a picture into a diagnosis. And we'll leave you with this last thought. For most of human history, what was going on inside our bodies was a total mystery. Now, with the push of a button, we can see inside ourselves with this incredible, breathtaking clarity. So now that you've had just a little glimpse of this amazing perspective, how does it change the way you think about the complex, beautiful machine that you get to live in every single day?